Well, dear colleagues, dear chairman and organizers, I would like to thank you very much for inviting me to the PHC 2021 and to give a talk on COVID-19 and liver diseases, lessons learned with a special emphasis on non-alcoholic fatty liver disease. So, liver involvement in patients, and this means hospitalized patients with COVID-19, can be seen in terms of elevated liver biochemistries in more than 30% of all patients. And there are several proposed pathophysiological mechanisms related to coagulopathy, hypoxia, can be DILI, and of course, the cytokine storm that could be related. I think the big question here is whether SARS-CoV-2 can directly infect the liver and can lead to mitochondrial dysfunction, block of autophagy, and also ER stress. Well, although the entry receptor is not highly abundant on hepatocytes and more abundant on cholangiocytes, it has been now shown in many studies that liver cells and also human hepatocyte and cholangiocyte organoids are permissive and can replicate SARS-CoV-2 infection. But when it comes to liver histological features, and these are features here depicted from autopsy studies, this means the most severe form of COVID-19 where the patients died, you can see here that typical features of, let's say, a viral hepatitis pattern with portal inflammation was not seen in these patients. I think the hallmark of liver pathology in COVID-19 is vascular thrombosis, either of the portal vein or a central vein, and mostly congestion of the hepatic sinuses with 35%. Of course, there can be some signs of inflammation, necrosis, stellate cell activation, and up to 40 to 50% had also liver steatosis, but it's less clear whether this is pre-existing or developing during the infection. But what is important that those who develop elevated liver enzymes, or let's say liver involvement, are at a higher risk of death. So you can see here the mean AST in those who died was 51 as compared to those remaining alive with 32. But this also tells you that there's not a typical picture of really high ALT levels like in viral hepatitis. These are moderately elevated AST. I think we can learn a lot about the pathophysiology behind the liver involvement when you look on the curves of the different liver biochemistries in these patients being hospitalized due to COVID-19. And what you can see here in blue are those who died and the others who survived. And you can see already in the beginning, the patient who died had higher AST levels as compared to those survived, no difference in ALT and GGT, and the increased AST was negatively correlated to the oxygen saturation, clearly telling you that hypoxic factors might be involved. However, in the follow-up, in those who died, GGT levels increases and more cholestatic pattern, as you can see here also with alkaline phosphatase. And this is correlated to an increase in inflammatory marker like the CRP as listed here. So when we do correlation studies, it has been shown from this study that the trajectories of liver function appear to be highly correlated with inflammatory markers like the CRP, LDH, or D dimers. And we know that these inflammatory mediators have been repeatedly associated with poor clinical outcomes in COVID-19. So from these data, it appears that in most instances, the liver involvement is part of an inflammatory process. So let's move forward to SARS-CoV-2 in patients with pre-existing liver disease and whether pre-existing liver disease is a risk factor for severe COVID-19 and death. Well, I think you all are aware that it depends on the stage of the liver disease, and if you have more advanced cirrhosis, the case fatality rate is really high, reaching 51% with a rate of decompensation and 64% for those with child POC. But what about those with chronic liver disease and without cirrhosis? And from huge population-based studies from UK, it appears that chronic liver disease is indeed a risk factor for death and increase the odds by approximately 2. But we also know that chronic liver disease can be linked to other comorbidities. So is it an independent factor? And when we look at the data coming from the COVID-HEP registry, it appears that in those with chronic liver disease but without cirrhosis, the risk of dying, and these are here in red um, marked, that it depends on the age of the patient and the number, or let's say the comorbidity index the patient show. And it's only if there are high comorbidity index or a high age that the people are increased risk of death. Well, and then of course, the most common comorbidity in the most common liver disease, and this is non-alcoholic fatty liver disease, is obesity. And you see here again, coming from this large UK-based study, that obesity, depending on the class of obesity, is clearly linked to the risk of death. So why is obesity so important? And it's most likely due to an exacerbated inflammatory status and a hypercoagulation tendency that is well known present in patients with obesity. So if you have a pre-activated immune system, the likelihood of getting a severe cytokine storm might be higher. And the same holds true for the hypercoagulation state that is associated with obesity that may increase all the factors associated with thrombosis and organ involvement according to endothelial dysfunction, thrombosis, and coagulopathy. And of course, there are several other comorbidities and diseases associated with obesity, especially also liver steatosis, that per se may increase the risk of severe disease. So the question is really, is non-alcoholic fatty liver disease an independent susceptibility factor in the SARS-CoV-2 pandemic? And the answer is probably yes. The earlier studies coming from China showed that patients with NAFLD had a higher risk of disease progression, more severe COVID-19, a higher likelihood of abnormal liver function, and interestingly, also a longer viral shedding. And from the same authors and the same group, they could also show that the D-dimer at admission as a factor associated with the risk of thromboembolism is higher if NAFLD is present as compared to non-NAFLD, and also the peak of the D-dimer was significantly higher. Another multi-center analysis also coming from China showed that these are especially the patients at a younger age, less than 60, with MAFLD, that are at increased risk of severe COVID-19. And here in those being younger, the risk for severe COVID was twofold higher, but no significant association was seen in the elderly population, meaning that if you're in the age, for instance, of 80 years, this is much more important and may override the importance of the underlying MAFLD. And in a second publication, they could further expand on this and showing that it's really an independent factor, and that here MAFLD increases the risk by nearly fourfold for a more severe course of the infection. And this was independent of diabetes and obesity. So why non-alcoholic fatty liver disease increases the risk of a more severe disease and probably liver involvement? And it could be shown in the last couple of months that NASH may have an impact on the expression of the entry receptor of the virus. This is ACE2, and the protease that is important for the cleavage of the spike protein required for cell entry. And if you compare obese without NAFL, you can see that obese with NASH have much higher expression of liver mRNA of the ACE and TMPRSS2 levels. But it's probably not only NASH. From a very nice study published recently in the journal, it was shown that even simple steatosis in obese women. These were women for bariatric surgery, and nearly half of them had only steatosis, no signs of NASH. But nevertheless, in those with steatosis, the expression of the entry receptor was higher in the subcutaneous, in the visceral adipose tissue, but also in the liver. Well, to summarize, and this is the last slide, to show you a meta-analysis I found quite interesting. They looked at comorbidities in COVID-19. And the question was which of the diseases increase the susceptibility of SARS-CoV-2 infection. And this was done by array-based gene expression data set from patients with 30 different frequently occurring diseases like malignant diseases, but also type 2 diabetes and NAFLD, non-alcoholic fatty liver disease. And among the 78 host genes that are implicated in COVID-19 susceptibility, they found highly similar gene expression pattern to that observed in COVID-19 in leukemia, in NAFLD, psoriasis, type 2 diabetes, and pulmonary arterial hypertension. But as you can see here from the colors, the differential gene expression pattern was particularly pronounced in leukemia, the more yellow or red the higher, and in NAFLD. So it's likely that the similarities in gene expression pattern offer a favorable environment to SARS-CoV-2 infection. So it could be that due to the global pandemic of non-alcoholic fatty liver disease, also our population is more susceptible or vulnerable to SARS-CoV-2 infection. So I thank you very much for your attention.